We're good to start.
Okay. Good evening, everyone. I'm Dr. Sravani, Consultant Emergency Medicine, working at Yashoda Hospitals, Secunderabad branch. So I warmly welcome to all the participants for today's webinar. So every Friday, we Yashoda Hospital Emergency Department come with few interesting cases. Along with the interesting cases topics, we even come with a journal club and research articles. The main motto of this regular webinar sessions is to increase the awareness and increase the knowledge among the participants. So today webinar is all about the journal club. So in this journal club, we are going to discuss regarding the sepsis trial. We have 3 sepsis trial, uh, Methylene blue, that is shocking blue trial in sepsis, Accon trial and the Censer trial. So we have 3 speakers for today's webinar. Dr. Vijay Reddy, who is a resident emergency medicine working at Yashoda Hospital, Secunderabad branch, who is going to deliver a talk on methylene blue in sepsis, septic shock. And the second is Dr. Nikhil. He is a resident. He's a resident emergency medicine working at Yashoda Hospital Censer Trial, Malakpet. And he's going to deliver a talk on Acorn Trial. So we have a chat box. At the end, if you have any questions, you can type in the chat box. We are going to answer the questions at the end. So over to you, Dr. Vijay.
Hello, good evening, everybody. Good evening, everybody. Today, I'm going to discuss about the shocking blue trial. Before this trial, I'm coming to the trial. Before this trial, methylene blue was used as a rescue therapy in the refractory septic shock patients. But this trial was aimed to assess when given adjunct therapy, like when early adjunctive methylene blue in patients with septic shock, this can it reduce the time duration of the vasopressors? Can it reduce like we are going to discuss about that. Coming to the introduction, sepsis. Sepsis is a dysregulated host response to any infection, which is characterized by the endothelial dysfunction leading to the increased vascular permeability and abnormal nitric oxide metabolism and vasodilation and other systemic derangements. Due to this, it may result into the shock, septic shock. According to the guidelines given by the Surviving Sepsis Campaign, uh, along with antibiotics, they have recommended the early fluid resuscitation as a cornerstone of the management. However, even if we resuscitate well with fluids, only half of the patients respond to the fluids, and only like their hemodynamic effects are for the short period. So early usage of vasopressors were needed to improve the organ perfusion. And out of the many vasopressors, norepinephrine is the first choice, and higher doses of this norepinephrine has high risks of adverse effects, which include the myocardial ischemia, tachyarrhythmias, and also the peripheral ischemia, and etc. These are the high risk adverse effects when given in the high doses of norepinephrine. Therefore, a combination of agents which are targeting the different systems involved in the blood pressure regulation and also the endothelial function has been proposed. This multimodal strategy could help to restore the tissue perfusion while decreasing the potential toxicity of the single agents. So out of which we are coming to the methylene blue. Methylene blue is a specific inhibitor of the inducible nitric oxide synthesis and enzyme soluble guanylate cyclase, which decreases the production of the nitric oxide and thereby uh, decreasing its effect on the like blood vessels. And this methylene blue also has a indirect vasopressor activity, so thereby increasing the tissue perfusion. And it is increasingly recognized that a higher exposure to catecholamine vasopressors like NORAD and all norepinephrine is associated with the increased risk of MODS, like multiple organ failure and also death in the septic shock. So, thus, in order to pave a way for adding catecholamine sparing agents to multimodal strategy, this randomized control trial was designed to assess if early adjunctive methylene blue administration could reduce the time to vasopressor discontinuation in patients with septic shock as compared to the placebo. Coming to the objective, this is the main objective to assess whether early adjunctive methylene blue can reduce the duration of vasopressor administration in patients with the septic shock. Trial design, it is a double-blinded randomized control trial, which was conducted at Academic Reference Center in Mexico. This trial was conducted in between the 2017 to 2022, and it is done in the as we already like most of the intensive care unit. Sepsis 3, like according to sepsis 3 criteria, the septic shock was defined as highly suspected and or confirmed infection, which requires vasopressors like norepinephrine to maintain the mean arterial pressure of more than 65 mmHg. And even after the adequate fluid resuscitation, when the serum lactates were more than 2 millimoles per liter, these these patients comes under the septic shock under sepsis 3 criteria. And the exclusion criteria, patients with who are like who with more than 24-hour patients who are on the like norepinephrine, patients who are on norepinephrine more than 24 hours, and pregnancy and major burn injury, and also like uh, refusal of consent and high probability of death within 48 hours, and the other shocks like hemorrhagic shock, obstructive shock, and hypovolemic shock, patients who are in these shocks, and also the personal or the family history of G6PD deficiency, as this methylene blue requires G6PD for its action, and allergic to methylene blue and phenothiazine, the patients who are allergic to methylene blue are excluded, and also recent intake of serotonin, selective serotonin reuptake inhibitors, as um, uh, methylene blue as an action of monoamine oxidase inhibitor. So it again causes the increase in the serotonin levels, which causes the serotonergic syndrome. And these are the exclusion criteria. And randomization, it was done, patients were randomly assigned to receive methylene blue, and was generated. The sequence was generated by the computer in 1:1 allocation ratio, and the critical care physicians were responsible for the assignment of intervention, and all the other clinicians, investigators, patients, and outcome assessors were blinded to the treatment received. Intervention, the patients who are assigned to the methylene blue are given received the IV infusion of 100 mg methylene blue in 500 ml NS over 6 hours daily for 3 doses, and the same the patients who are assigned to the control group received the same dose of IV fluids 500 ml of NS without MB. And in order to mask this MB these infusion bags and the lines, they have prepared specially with the opaque envelopes in order to avoid the visual identification of this infusion. And the patients in both the groups, common in both the groups, the vasopressin was initiated only after the norepinephrine dose is more than 0.25 micrograms per kg per minute, and it was initiated, vasopressin was initiated at the dose of 0.03 units per minute. And the Evaluation of volume responses were repeated at least three times each day, as long as the vasopressors were needed, and both the groups were infused with the hydrocortisone 200 mg per day. It was given continuously, and it was stopped only after the vasopressors was discontinued. And a vasopressor tapering protocol, which was led by the nurse, consisted of the norepinephrine titrated at 15 to 20 minutes interval to maintain mean arterial pressure between 65 to 75 mmHg until the complete discontinuation. And also, the vasopressin was progressively withdrawn only after the complete discontinuation of norepinephrine. Coming to the measurements, there were like before allotting the patients to the intervention, this they have recorded the information of the patients. They took the data, demographic data, ventilator data, laboratory data, and also the norepinephrine dose at the time of randomization. And also norepinephrine, they have measured, they have recorded the dose of norepinephrine immediately after each dose of intervention drug, and also at the 24 hours and at the 48 hours post treatment, and for a total of 4 days. And at the time of randomization, they have done the multi organ point of care ultrasound to assess the different organs in the of the patients, and it is done only by the expert personnel. And they have also calculated the ejection fraction, and also the methemoglobin capillary saturation. Coming to the outcomes, the primary outcome to be assessed is the discontinuation of all the vasopressors for at least 48 consecutive hours. And the secondary outcomes are the vasopressor free days at 28 days, and the mortality at 28 days, serum lactate levels, days on mechanical ventilation, and length of the stay in ICU and hospital, and changes in the serum creatinine, bilirubin, AST, ALT, and partial pressure of oxygen to fractionated oxygen ratio, and ejection fraction after the intervention. These are to be these are the parameters to be checked in this trial. They wanted to know these parameters in this trial. And coming to the sample size, the sample size of this trial was 92 in between 46 per group. Initially, the 308 patients were assessed for eligibility, out of which 216 were not eligible because some of them has COVID-19, and some are pregnant, and some have major burn injuries, and some denied the consent, and some are on the vasopressors for more than 24 hours. And only 92 of them, 92 of 308 are under randomization. 46 were assigned to the placebo group, and the 46 were assigned to the methylene blue group. And methylene blue group, one withdrew the consent after the first dose. Yeah, here you can see the characteristics. Almost both the groups having the equal same almost the same characteristics. Like you can see the age in the methylene blue group is 46, and the control group it is 47. You can see the hypertension and diabetes almost the same, 17 and 18. And the major source of infection in this trial is coming from the pneumonia and the intra-abdominal infections. And you can see the acute kidney injury also, like in methylene blue it is 22, and it is in control. In control it is 20. So you can see almost same characteristics, same number of patients in between the same group have the same characteristics, same number of characteristics. Coming to the primary outcomes, yeah, you can see the vasopressor discontinuation. The time to vasopressor discontinuation was 16 hours, only 16 hours in the methylene blue group, and it is in 94 hours in the control group. You can see the change of almost 25 hours it's between them when used along with methylene blue. The vasopressor, the time to vasopressor, time of vasopressor administration was less It only took 69 hours, and in the control group it is 94 hours. And a total of 5 out of 45 patients in the methylene group and the 13 out of 46 patients in the control group required reinitiation of NA. Here also you can see the superiority of the methylene blue. Methylene blue. Only 5 out of 45 patients and 13 out of 46 patients. You can see like almost the difference of extra 8 patients in the control group are like require reinitiation of the vasopressor, norepinephrine within 48 hours after discontinuation. And the secondary outcomes, mm, patients in the methylene blue group had one extra day of vasopressor free days. One extra day of vasopressor free days at day 28 and a shorter ICU length of stay and shorter hospital length also. And whereas the lactate levels and the days on the mechanical ventilation, mortality, and at 28 days were similar in both the groups. Here you can see uh, time to vasopressor discontinuation in MB group is 69 and in control 94. The p-value is very much significant. As we all know, p less than 0.05 is significant. So you can see in this time to vasopressor discontinuation and vasopressor free days and cumulative fluid balance at 4 days. All these are less than 0.05. P-value is less than 0.05. So it is significant, very much significant. And here also in regarding to the ICU length of stays, ICU length of stay and hospital length of stay, P-value is less than 0.05. So this by this thing you can say when used when the patients with the early adjunctive methylene blue therapy, it is very much like decreasing the duration of vasopressors, other norepinephrine, other vasopressors administration. Yeah, coming to the adverse effects. Adverse effects, the most common adverse effects are as we all know, when given this methylene blue, the urine color will be greenish discoloration of urine, greenish blue discoloration of urine. And the maximum, and the other adverse effects will be maximum with hemoglobin saturation was significantly higher in patients of the MB group. As we are giving only like per day, we are giving almost 2 to 2.5. It won't be that much it won't cause that much effects in this group. Regarding other potential adverse effects, both will have the same thing, the change in the ejection fraction and partial pressure of oxygen by fractionated oxygen ratio, serum creatinine, bilirubin, and liver aminotransferases were not different between the groups after the intervention. Here you can see these changes. This is in the placebo group, this is in the methylene blue group. There is not much difference in the fraction ratios. Here you can see the creatinine levels. So there is also not much any increase or decrease in both the like before and after in methylene blue group and in the placebo group, control group. Coming to the limitations, as it is a single center study and a relative shorter ICU or hospital stay, one cannot assess the long-term effect of the methylene blue on the patients cannot be ruled out. And most patients were managed in other departments at the time at the moment of septic shock identification before admission to ICU, and the lack of trained healthcare staff and resources might have led to the suboptimal resuscitation and worse patient status, as shown by relatively higher doses of Na. Although there is a time, there is the time between the allotment and the intervention is less, the improved result of the MB like cannot be like in early stages. Improved response of the MB in the early stages cannot be ruled out, as it is suggested. That early use of MB in like can have is more effective in the early stage of the disease. And as it took 5 years almost, we have discussed in the starting part, it took the 5 years to complete, and the COVID-19 pandemic has slowed down the recruitment rate. And during this time, there is this survival sepsis campaign guidelines were updated. These guidelines were updated. However, there were not much changes. The only change was you need to give only IV crystalloids. The few changes were done regarding the IV crystalloids. Here we have given the NS 0.9% NS. This is the only change. Other than that, there is no change. As we have given this trial has given the IV corticosteroids infusions also, and this trial did not measure any cytokine or nitrate serum levels to confirm the mechanism of the actions of the methylene blue, and it excluded the COVID-19 patients, and 100% blinding was not maintained as because the patients with the who are administered with the methylene blue as the urine color, we like urine color is blue green color, uh, greenish blue green color. Everyone like who is assessing the patients might come to know that they have administered, these patients are come under the methylene blue group. And due to the small number of patients, mortality trends were also not assessed. And these are the limitations. And coming to the conclusion, early adjunctive methylene blue administration reduced the vasopressor duration and cumulative fluid balance and ICU and hospital length of the stay among the patients with shock as compared to the placebo. And there were no adverse effects when the patients are on methylene blue. Yeah, thank you.
Thank you, Dr. Vijay, for the talk. And next we have Dr. Nikhil Reddy from Somajiguda. Dr. Nikhil, can you please share your screen?
Yeah, good evening, everyone. I'm Dr. Nikhil Reddy, resident in Emergency Medicine, Somajiguda. Today, we are going to discuss on the topic, which is Censer Trial. Yeah. Coming to the Censer Trial, today we are going to be discussing on this grossly, like we are going to discuss on background, hypothesis, methodology and study design, results and analysis, discussion and conclusion, and applicability in our day-to-day practice. Coming to what is the Censer Trial? Censer Trial is nothing but it shows the yeah, advantages of using early norepinephrine in septic shock resuscitation. It is a randomized control trial. Coming to the clinical question, how does this Censer Trial can be applicable to the daily resuscitation, and what is the use of uh, resuscitation with non-epinephrine? These are the main questions which we get regarding while we talk about the Censer Trial. Coming to the question, does early use of low dose norepinephrine in adults with sepsis increases shock control by 6 hours compared to standard care? Coming to the background can be seen like it it can be discussed with an association between early vasopressor use and improved outcomes. Standard management of septic shock includes IV fluids, early antibiotics, and source control. And traditionally, patients who come up with all sepsis are resuscitated with IV fluids, and hypotension will also be given with IV fluids first. And the optimal timing of introduction of vasopressin therapy in patients with sepsis and septic shock is not known. Coming to PICO. PICO is nothing but population intervention comparison and outcomes. Coming to the population part, this trial was done from 2013 to 2017 in Thailand and Srinath Hospital in Bangkok, which it's conducted by Department of Medicine. This is the largest university-based international tertiary referral center in Thailand. Coming to the intervention part, they have given 4 mg non-epinephrine mixed with 250 ml of 5% dextrose in water for a final concentration of 16 micrograms per ml infused at a constant non-titrated rate of 0.05 mcg per kg per minute for about 24 hours. And they are compared with the normal placebo, which in which 250 ml of infused at an equal constant non-titrated rate of 0.05 micrograms per kg per minute for 24 hours. Coming to the inclusion criteria, in this inclusion criteria, they have included an adults over 18 years and older presenting to the ED with hypotension and suspected infections. Hypertension defined as hypertension people who has MAP less than 65 mmHg were required to meet the diagnostic criteria for sepsis according to 2012 sepsis surviving sepsis campaign, and they must meet the criteria for less than 1 hour of prior to randomization. Coming to the exclusion criteria, septic shock more than 1 hour, and any patients with other ongoing diseases such as CVA, acute coronary syndrome, acute pulmonary edema, status asthmaticus, and active arrhythmias, active GI hemorrhages, pregnancy, seizures, drug overdoses, trauma, and need for immediate surgeries or advanced stage cancers. These all are the exclusion criteria. In this, initially 456 patients were evaluated. In this, approximately of 136 were excluded due to multiple exclusion criteria like prolonged shock more than 1 hour. 21 of them had end of life plan. 20 were enrolled with other trials. 19 had other exclusion criteria, and 19 has mean blood pressure more than 65 mm of Hg, and 15 did not have any given any consent, and 11 of them were referred to other hospitals. In this, 320 have underwent a randomization, during which 162 have come into norepinephrine administration group and 158 have come into placebo, in which 162, 7 have withdrawn the consent, and from the 158 group, 3 have withdrawn the consent. Initially, finally, the test was done between 155 people who underwent with norepinephrine administration and 155 under with normal placebo. Coming to the primary outcomes, nothing but shock control rate by 6 hours after diagnosis of sepsis with hypotension. What is shock control rate? Shock control rate is defined as nothing but sustained MAP more than 65 mm of Hg plus evidence of adequate tissue perfusion. Now coming to sustained MAP. When will you call it as sustained MAP? Sustained MAP is defined as mean arterial pressure greater than 65 mm of Hg for 2 consecutive measurements apart 15 minutes apart. And when will we call as evidence of adequate tissue perfusion? Adequate tissue perfusion is defined as continuation of urine output more than 0.0 ml per kg per hour for 2 consecutive hours, or decrease in serum lactate by more than 10% for initial levels. Coming to the methodology, this is a phase 2 double-blind placebo-controlled randomized controlled clinical trial which has been conducted from 2013 to 2017 in a single center, which is a Srinath Hospital in Bangkok, Thailand. All the patients were informed, consents were taken from the patients, patient attenders, relatives, and attending physicians and nurses were all blinded to the study assignment. Coming to the intervention details, both treatment groups also have given with fluid resuscitation at the same time, as in norepinephrine group and placebo group. As per sepsis surviving campaign guidelines, which is 30 ml per kg, it fails to intervention. It fails to achieve MAP more than 65 in non-epinephrine and placebo plus fluids in which open labeled norepinephrine is permitted. Coming to the outcomes, in placebo group, shock control by 6 hours is 48%, but in non-epinephrine groups, it is about 76%, and the p-value is 0.001. P-value is nothing but it is a quantification of random chance in which is statistically significant, and mortality at 28 days in only placebo group it is about 22%, and in non-epinephrine group it has come around up to 16%, and the p-value is also less than 0.05, which is p is 0.15 in this. Coming to the additional results, other secondary outcomes and additional results we see for secondary outcomes in which achievement of target map more than 65 mm of Hg, urine output about 0.5 ml per kg, and lactate clearance is 10%, all significantly higher in early non-epinephrine groups. And coming to there was no differences in mechanical ventilation or renal replacement therapy, and less pulmonary edema and arrhythmias in early non-epinephrine group. Coming to the interventions given, more use of open label non-epinephrine in placebo group is about 80% versus 68%, and similar volume of fluid in first 6 hours in both groups, which is near to 2.5 liters. Coming to the strengths of the study, in which it was the first prospective randomized study. An important clinical question that will add to the literature regarding optimal timing of vasopressin use in septic shock, allocation, concealment, blinding, initiation to treat analysis, complete follow-up have been achieved. Participants matched and balanced in baseline characteristics. Coming to the limitations of the study, in which it is a single center trial and is in a developing nation, reduces external validity, and primary outcome was not on patient oriented outcome as well as many of the secondary shock control outcomes. Secondary outcomes of all cause mortality was patient oriented, but trial was underpowered for this outcome. Can be considered hypothesis generated for further trials. Application and further study. Censer study leads support to early use of vasopressors in septic shock. However, far from definitive. So, a range of clinical practices regarding vasopressor timing remains acceptable. For more information on vasopressors, there is another study called Clover's trial, which was done on 2,300 patients, which is a multi-center randomized control trial for early vasopressors in septic shock, which was reporting in 2021, should provide more definitive answers. These are the references from which I have taken up this information. Thank you.
Thank you, Dr. Nikhil. And now we have a third presentation by Dr. Murali from Malakpet branch. Dr. Murali, please share your screen.
12
minutes.
12 minutes. 12. ఆపింది చూసా, లేకపోతే కనిపిస్తాం కదా.
Good evening, everyone. Today's my topic in the general club is Acorn Trial, and any acutely ill adult patient that who are at risk of infection with the resistant gram-negative bacteria, guidelines recommend the administration of cefpime and pipzo, which are anti-pseudomonal antibiotics, which covers the both MRSA and pseudomonal species. And why they are chosen these things? Because they have the similar efficacy, but the selection between the two drugs are the difference in the safety profiles. That is a neurological dysfunction, acute kidney injury respectively, which are based on the observational studies. The PIPSO has the potential for the acute kidney injury, especially with the use of the vancomycin. So the research question was for a patient with acute infection, the use of cefpime and PIPSO, does it affect the risk of AK or neurological dysfunction? So to our knowledge, no randomized controlled trial has compared the cefpime versus PIPSO. Therefore, it is unknown whether the risk of the AK or neurological dysfunction differ between the two drugs. To compare the adverse effects of the cefpime and PIPSO in adults, they have conducted a trial, which is the Accon trial. And I kept this slide because to remind that Accon is a small fruit, so you can remind this trial. The methodology of the study is it is an open label parallel group randomized comparative study. It was done at the Vanderbilt University at United States. They have done the study during the November 10, 2021 to October 7, 2022 with the study population of 3,806 people. And they have randomized these people using a tool in the software within the electronic health record with simple randomization without stratification. And they have randomized these 3,806 people and included the 1,214 people in the who are receiving the cefepime and 1,297 people who are receiving the PIPSO, and they are excluded almost 1,172 people with using the tool software tool. And the inclusion criteria for this study was adults who are more than 18 years of age and in the ED and medical ICU, and those who were initiated on cefpime and PIPSO within 12 hours of the presentation to the hospital. And the exclusion criteria was the patient who are allergic to cephalosporins or penicillin, and the patient who received more than one dose of the anti-pseudomonal cephalosporin penicillin group of drugs within the previous 7 days. And the exception was the patient who received other anti-pseudomonal antibiotics were included, and they excluded the patients who are incarcerated during the study. And treating clinical determined that any one of the two drugs represented the better treatment option for that patient were excluded. And the intervention, they used the patient's glomerular filtration rate as a basis, and with the use of the software tool, they have software developed a recommended dose and frequency which were given to the patients. And the standard administration protocol for these antibiotics is the cefpime 2 gram IV over 5 minutes 8th hourly, and PIPSO the 3.375 gram IV bolus over 30 minutes, and followed by 8 hours of infusion of the same dose over 4 hours. And the data, the following data were included like demographics, race and ethnicity, diagnosis, pre-enrollment, kidney function, medication administration, vital signs, laboratory values, microbiology cultures, organ support therapies, SOFA score, CAM-IC score, RAS score, GCS score, date of admission, transplant, discharge, vital signs at the hospital. And all this data they have enrolled in the software, and they have given a outcomes which were categorized as primary, secondary, and exploratory outcome. And primary outcomes were taken at the day 17 with the events they considered are highest stage of AKI and death, and which were scored based on the ordinal scale with 0 to 4. And the 0 shows the no new or worsening AKI. 1 shows the creatinine level of 1.5 to 1.9 times the baseline, and or else increase in the 0.3 mg per deciliter of the creatine. Score 2 includes the creatine 2 to 2.9 times the baseline, and 3 was the creatine 3 more than 3 from the baseline with the creatine of more than, or else with the creatine of more than 4.4 milligram per deciliter, or any inclusion of any renal replacement therapy. And 4 includes the finally the death. The events in the secondary outcome included were the incidence of any major adverse kidney events at the day 14. And the other thing is number of days alive and free of delirium and coma within the 14 days. The exploratory outcomes they have taken at the day 28 or within 28 days, which include the major adverse kidney events, delirium and coma free days, kidney replacement therapy free days, vasopressor free days, ventilator free days, ICU free days, and hospital free days. And all these outcomes were the analysis was done And based on analysis, the size estimated to be like initially they designed to enroll 2050 patients to provide 80% of the statistical power to detect an odds ratio of 0.65 in the primary analysis, but 75% patient association between the PIBZO and AK has been hypothesized to be concurrent use of the vancomycin and timing of the trial interim analysis. And so for these, because of these reasons, the sample was re-estimated to the population of 2,500 with the assumption of two-sided alpha value of 0.05. And based on that statistics, the outcomes, they are given the statistics values, which will be discussed in the which I will be briefly I will be discussed in the next slides. These are the comparison of the PIBZO and the SafePine in the bar plots, which were established for the like number of patients alive and hospitalized with the randomized to SafePine and PIBZO, and all the results were given with all the included patients were 2,511 people were included in the primary analysis, and 7% enrolled in the ED, 2% receiving vancomycin enrollment, and median time period between the presentation and enrollment is 1.2 hours. And the most common source of infection were intra-abdominal source, pulmonary source, sepsis, mechanical ventilation, vasopressor, CKD, and assigned antibiotic was received for a median of 3 days in each group. And the primary outcome, the event, the highest stage of the acute injury or death by day 14 for the SEPPIM was stage 3 AK, it was 7%, and death in that patient was 7.6%. For the PIBZO, stage 3 AK, 7.5%, and the death 6%. And all this for all this result, odd ratio was 0.95 with 95% confidence interval with a p-value of 0.56, and this result was not statistically significant, and result remained consistent in the adjusted analysis and all the pre-specified sensitivity analysis. And for the secondary outcome, the incidence of the major adverse kidney events at day 14 for SEPPIM is 10.2%, for PIBZO is 8.8% with 95% confidence interval. And for the patients, for the days alive and free of delirium at 14 days, for specimen was 11.9 days, for PIBZO 12.2 days with the odds ratio of 0.79 with 95% of confidence interval. And the delirium or coma incidence for SEPPIM was 20.8%, for PIBZO is 17.3% with 95% confidence interval. And the strength of this study is it asks a clinical important question about the two antibiotics which were commonly used as empirical treatment for the septic adult patients. And it had a good methodology which includes the large randomized clinical trials, concealment of the group assignment until the enrollment to prevent the selection bias, and enrollment occurring at the median of 1 hour after the hospital presentation to minimize the exposure to antibiotics prior to the enrollment. And it was overseen by the independent data and safety monitoring board was there, and almost more than 95% of the patients who receiving the antibiotic were randomized to the groups which were fairly balanced at the baseline. Just under the 50% of the enrolled patient already had some form of the kidney injury at the time of enrollment and are at the highest risk of worsening kidney injury and death. And it included the large proportion of patients receiving the concurrent vancomycin at the time of enrollment. Limitations of the study was treating clinicians determined the duration of the anti-pseudomonal antibiotic therapy and whether to administer the additional antibiotics which could alter the number of days an antibiotic could be received. And it was a single central trial which may limit the generalizability at other institutions, and patients and clinicians were not blinded to group assessment which affect the subjective clinical assessment. And in 1 in 5 patients in each group received at least 1 dose of unassigned antibiotic within the first 14 days, which decreases the separation between the groups and increases the risk of the between the group difference in the outcomes. And the pre-illness creatinine was not available for all the patients. Patient who only received a median of 3 days of treatment with antibiotic, which will minimize the risk of the AK neurological dysfunction. And PIBZO was administered as an extended infusion. So because of this, the results of this trial may not apply at other institutions. because of different dosing strategy, and it was unclear if outcome assessors were blinded, and it is a non-consecutive enrollment. Clinicians excluded the patients from the trial when they felt one agent was superior to the another for that particular patient, which biases the results towards the null. So this particularly true with the PIPZO, where clinicians have excluded the patients from the trial when felt they were at the risk of the renal adverse events. The discussion of this topic was the receipt of the PIPZO did not appear to affect the risk of the AKI at any any time points during the study. Overall, not among the patients receiving the vancomycin at the enrollment, and the receipt of the cefpam did seem to cause increased delirium and coma compared to the PIPZO. So the neurotoxicity of cefpam include the coma, delirium, encephalopathy, and seizures. So conclusion of this topic is among the hospitalized adults in this trial, treatment with the PIPZO did not increase the incidence of AKI or death, and treatment with cefpam resulted in more neurological dysfunction. Take home point for this topic is it is a large single center randomized controlled trial. We have seen that PIPZO didn't increase the incidence of AKI or death compared to the cefpam, but cefpam did result in some neurological dysfunction when compared to the PIPZO, and both the drugs have the similar efficacy of the two medications. But barring some contraindication, it seems empirical treatment in the septic patient with PIPZO is better way to go. These are the references. Thank you.
Thank you to all the three participants, Dr. Vijay, Dr. Nikhil, and Dr. Murali, for the informative talk. And now we have two questions in the chat box. First question is, can we give methylene blue in septic shock? If yes, why? I think Dr. Vijay can answer this question.
Yes, ma'am. We can give methylene blue in septic shock, as it inhibits the inducible nitric oxide synthase, thereby decreasing the production of nitric oxide.
Okay. Basically, I think okay.
And it also has the indirect vasopressor pressure action on the blood vessels, thereby increasing the perfusion of the tissue perfusion and increasing the blood pressure.
Okay. I think I personally have an experience with the methylene blue administration. So basically, this methylene blue, previous in 2000, 2001, they used to use in a refractory hypoplasia in cardiac bypass cases. But nowadays, I think since 1 year, they have started doing trials, early methylene blue as an adjunct methylene blue in instead of vasopressin, early. So in my case, like actually 1.5 months ago, we have received a case, around 50 years old male, known CAD with severe LV dysfunction, with presented with acute LVF and UTI symptoms. Patient was on BiPAP, and suddenly after administration of antibiotic, started developed anaphylaxis, and suddenly patient collapsed. So we have started prolonged CPR. In spite of 1 hour of CPR, patient still had a persistent shock in spite of giving all the medicines. Then we took a decision to give methylene blue. There we have administered 1 mg per kg methylene blue. So within 30 seconds of administration, we got ROS achieved, and we got a good central pulse, and patient had a very good outcome. So this is my experience with methylene blue. So I think previously it is used in cardiac bypass, and we can even use in anaphylaxis, and now in the septic shock. But still, even here, the mechanism is same. So it blocks the enzyme guanylase cyclase, so that it reduces excessive nitric oxide production, so that it alleviates its vaso relaxing effort in the vascular smooth muscle. So it restores vascular tone and increases the BP. So this is all action about methylene blue. Okay. So I think, so we have one more question in the chat box. Why noradrenaline is used as a first-line vasopressor in septic shock? And is there any other studies comparing the use of noradrenaline with other vasopressors? I think Dr. Nikhil, this is your topic. I think you can answer. Dr. Nikhil?
Initially, there is no other specific studies related to relating nor comparing noradrenaline with any other vasopressors as such. But according to the Censer trial, norepinephrine is the main primary thing which we have to administer, because it has both alpha 1 and beta 1 properties. So norepinephrine is preferred much higher than any other vasopressors.
Okay. I think to add on, we have one trial called VAS trial, vasopressin versus epinephrine. According to that study, there is no much of benefit. Even if you start vasopressin in early stage, the mortality is the same. So, as you said, so norepinephrine is preferred more than vasopressin because it has a peripheral vasoconstriction, even a cardiac contractility is also there. So, and usually I think in our regular practice, if we see in any septic shock patients, we first start with fluid resuscitation, starting with basically we prefer with RL, and with fluid, we check the response of the fluid, assess the fluid response with ultrasound guided. And if patient is really euvolemic or hypovolemic, so rather waiting for this 30 ml per kg, calculating the dose and giving the fluids, I think I prefer, in our practice, we prefer starting with early vasopressors. I think this will help the patient in septic shock so that the patient will have a better outcome. I think these are the only two questions in the chat box. Okay, I think we'll end the session, and thank you, Dr. Vijay. Thank you, Dr. Nikhil, and thank you, Dr. Murali, for the informative talk. Have a nice day.
Yeah, thank you.
Thank you.